So John, welcome. We're at ASCO. I'm joined by a surgeon who believes that some patients might need adjuvant therapy, that they actually didn't get it all. You had a brilliant study that you presented orally at the meeting in bile duct cholangiocarcinomas.
Sure.
Tell me about the trial and how it went.
So this trial is almost geriatric now, in that we wrote the proposal about a decade ago. And bile duct cancer, as you know, is not one of the most common cancers, and it's taken a while to accrue the 450 or so patients in it.
Do you think you're seeing more bile duct cancer, by the way? It seems like it's increasing in my opinion.
You see, I think that's what a lot of people say. I think that might be the case, but also it just might be our diagnostics are better and you pick up more, and I think that's most likely to be the case.
Sorry,
but there is controversy about that.
Yeah.
So we did this trial purely in the UK. We were able to recruit just about all of the suitable patients in the UK by the nature of our cancer research networks. So it was a successful trial, but it still took time to accrue. The other interesting thing is that when we started it out, we assumed that we'd have approximately 20% 2-year survival, whereas in fact it was 60%.
Wow.
So we had to change, the DMEC allowed us to change
Are
the
you better
powering of the study.
surgeons than we were before, or why
No,
why were we so off?
So I think to be recruited for the trial, okay, you had to have a big operation for biliary tract cancer, and for a hilar cholangiocarcinoma, that is a massive operation. Then you have to get better, and then you have to be fit enough to receive adjuvant chemotherapy.
So selection.
So it's clearly a highly selected patient group, and I think that's why the outcomes are better than you would get from the literature.
Was there a requirement between surgery and the timing when you had to start chemo, or could that be pretty loose?
Sure. No, it wasn't loose. It was within 16 weeks.
16 weeks.
When we started the trial, it was 12. We had to amend the protocol because a lot of patients just were not quite ready at that stage, so we moved it to 16, and that seemed to work pretty well.
All bile ducts were included?
So all bile duct cancer was included, including gallbladder, which is a slightly controversial one, but I think the decision to do that was in retrospect correct.
Ampullary?
Ampullary, so the most common site was lower common bile duct cholangiocarcinoma, but that true ampullary cancer was excluded. Okay, so it's what was called by the pathologist a cholangiocarcinoma.
Tell us what you found between the two arms.
So there was basically a 15-month improvement in the overall survival, median overall survival, in the capecitabine arm in the first analysis that we've done, which is when all patients have been followed up for 2 years or more.
So this 15-month is difference in relapse-free survival?
Yeah. No, this is overall survival. Yeah, the primary endpoint was overall survival. Yeah. Now, by intention to treat analysis, this just missed being statistically significant. But the sensitivity analysis that was built into the protocol, it was highly significant. And in that sensitivity analysis, we corrected for a number of prognostic factors, including sex, disease site, lymph nodes.
So essentially a positive adjuvant study with simply capecitabine, right?
Yeah, with simply capecitabine.
Against surgery alone. We haven't seen a control arm like that in a long time, which was needed, right? We didn't have a standard of care in this disease.
I think there's no standard of care in the disease, and I think we would contend that capecitabine now is the standard of care and should be the control arm for future studies. Yeah. Now, some may argue about the ITT versus the per protocol analysis versus the sensitivity analysis, but the reality is nobody's going to do this again. Yeah. You know, the data's the data, and I think it's strong enough, I think, to make it clear to the community that that's what they should be doing.
Yeah. Just a real quick, are the different kinds of bile duct cancers, different locations, they have a different prognosis in your study?
So we've a lot of data we haven't actually analysed yet, but what we described in the presentation was looking at the interactions, and so capecitabine seemed to have a similar positive effect in all of the sites with the exception of possibly hilar. Now the problem is we're starting to cut up the numbers too much to make any positive call. It's just not, you can't make any statistical conclusion. But there is the trend that hilars may not be doing gaining as much benefit from the capecitabine. Now, it might be because the incidence of R1 resection is a good bit higher in hilar cholangio, and we know from the subgroup analyses that R0 resections seem to get more benefit than R1 resections. So it may not be biology, it may just be the technical difficulty in the surgery.
So CAPE is at least one option in the adjuvant setting, proving adjuvant therapy does work in this group of patients, no radiation in your study. What's the next study? Now, I'm a believer that these tumors are cousins of pancreas cancer. We have positive data with GEM-CAPE. We also know in the US we use a lot of GEM-CIS in the adjuvant setting based on no data. What's the next trial?
Right, so before we concluded recruitment to BILCAP, we set up another pan-European study led by Dirk Arnold, and that was looking at GEM-CIS versus observation. Now, that's recruited a couple of hundred patients. Now, we've had a meeting about this. I think the consensus is that we can't really go on with that.
With the observation
arm. So that's going to be changed to capecitabine
as the control arm.
As a control arm. So there was discussion about whether the whole trial should be changed to CAP versus GEM-CAP, and I think there is an argument for that. But we have already got a trial running. GEM-CIS works in advanced disease. I think it's a reasonable option. Except the Prodigy study, which was GEM-OX, was not particularly spectacular. But I think for the moment we're going to go with the comparison with GEM-CIS, and we'll do an interim analysis and just see whether there's a signal there or not.
John, congratulations. It's always fun to set a standard of care, and setting it for oncologists from a surgeon is a particularly joyful moment.
Well, of course, this is a big team, and I'm the chief investigator, but my colleagues, particularly Professor John Bridgewater, has been really key to delivering this trial. So it's not surgery alone, let me assure you of that.
Congratulations again.
Okay. Thank you.